The thyroid is actually fairly easy to scan because it's very close to the skin. If we hyperextend the patient's neck and use a high-frequency linear transducer, we should be able to get pretty nice images on almost everyone. Now, nodular thyroid disease is the most common disease of the thyroid. Some of those nodules are going to be benign, some are going to be malignant, and some are going to be in between where we can't discern sonographically. What I'd like to do in this talk is to describe what we call the pattern-based approach to nodular thyroid disease. Some nodules are clearly benign by initial ultrasound, and we can either follow those or not follow those if they're completely benign. Others are malignant and have malignant characteristics that really need no further workup or evaluation. They need to be referred for either an FNA or biopsy or excision. And then there are those, of course, that are in the middle that we can't discern, that we will refer to an endocrinologist or will follow up at intervals. Nevertheless, most of the time we can make a decision with nodular thyroid disease on our original ultrasound evaluation. The ability of ultrasound to find nodules in the thyroid is actually unsurpassed by any other imaging modality available to us. If we scan everyone, whether or not they have symptoms or whether they have palpable nodules, we'll find that somewhere between 4 and 7% of all the patients scanned will have nodules of their thyroid. Now, most of these are benign. If we look at it from the other perspective, autopsy studies, autopsies on patients that have no disease and did not die from thyroid disease, up to 45 to 50% of those patients will have some discernible nodular thyroid disease on autopsy studies. The challenge here is to decide what's benign and needs no further follow-up and what is actually suspicious and needs further follow-up. The most common form of cancer of the thyroid is actually papillary carcinoma. And papillary carcinoma is a non-aggressive form of cancer, and most people don't die of papillary carcinoma, even if they're diagnosed late. The challenge and the goal that we have is to discern which patients actually have benign disease, and the evaluation can actually stop with the first ultrasound so that we can avoid expensive interventions, and which patients actually have more malignant suggestions on their ultrasound and need further workup and follow-up. We'll teach what's called a pattern-based approach to the diagnosis of thyroid nodules in this segment, and hopefully this will allow us to avoid all those expensive interventions that could be done for people that really don't need them if they have benign thyroid disease. Well, let's begin by looking at some ultrasound technique. The ultrasonographic examination of the neck is performed with the patient in a supine position. The patient's neck is hyperextended with a pad or towel centered under the shoulders to optimize exposure to the anterior neck. The examiner sits at the head of the bed and rests his or her elbow or forearm on the adjacent bed next to the patient's head to steady the transducer. High-frequency linear transducers provide optimal resolution and visualization and is easy in most patients. How about some pitfalls in normal thyroid? Well, the normal thyroid has a fine, homogeneous echo texture that is more echogenic than the adjacent muscles. In the periphery of the thyroid lies the carotid artery and internal jugular vein, marking the edge of the normal thyroid. In older patients, small, insignificant echolucent accumulations of colloid material are commonly seen. The thyroid capsule is a thin, echogenic line surrounding the gland. Color flow Doppler imaging of the normal thyroid demonstrates minimal flow signal, which is usually located near the poles of the gland. The normal thyroid has circumferential vessels that go completely around the gland with feeder vessels entering and exiting the gland. The echo texture of the thyroid should be similar to liver texture and almost identical to testicular texture in the male and normal pancreas. It has a soft grayscale appearance and is usually moderately vascular. Neck muscles are striated and encapsulated and less echogenic than adjacent thyroid tissue. The footprint of your transducer is usually 30 to 40 millimeters and will limit the amount of gland you can visualize. You may want to use the extended view or panoramic view option on your machine if it's possible. If you do not have an extended view or panoramic view on your machine, you can use split screen to visualize both the right and the left lobe of the thyroid at the same time. It is important that you not flip your transducer as you go from left to right, as the appearance will be identical and you will not be able to determine which lobe you are looking upon when you review your images. Note the color flow into the normal thyroid gland with large vessels surrounding the outside of the thyroid and smaller vessels penetrating the thyroid. This is the split screen approach to viewing the entire thyroid on one image. The right side was first obtained, the screen was split, and the left side was obtained, and the two were pasted together. So you get a nice view of both the right and the left side of the thyroid gland in one. Most of the modern machines will provide the ability to do an extended field of vision view like this view. It allows you to visualize the entire thyroid in one image. In this image, we see the entire right and left lobes, both carotids, and some of the soft tissue of the neck on both sides. It's good to recognize what is and what is not thyroid. Not everything that looks like a thyroid is the thyroid gland. There can be many masses of the neck which are not thyroid. There are brachial cleft cysts, thyroglossal duct cysts, which, by the way, are the most common congenital cysts of the neck. There may be enlarged lymph nodes, metastatic lymph nodes, and vascular abnormalities of the carotid. These are examples of two children who have neck masses but do not have thyroid disease. These are thyroglossal duct cysts. Well, what about this woman? Is this thyroid disease? This was a patient I scanned overseas. She said she had had this neck mass for years and asked that I look at it to see if anything could be done. This was an area where endemic multinodular goiter was prevalent, and I admit I was less than enthusiastic about scanning her. I considered the diagnosis obvious. It was long-standing. It surely was multinodular goiter. However, when I did scan her, I was quite surprised. What do you see? What do you think? Besides, of course, the ultrasound gel on her neck. Well, here's the scan of the thyroid gland. Her thyroid is slightly enlarged. Note that the thyroid extends beyond the carotid on the right. There is indeed a nodule in the upper portion of the right side of the thyroid that appears quite benign, but that doesn't explain the large neck mass. Whoa! So what's this? Note the heavy pulsations over the thyroid gland and the hypoechoic cystic-like mass overlying the thyroid gland. What would you do next? Color, of course. This large cystic mass was the carotid artery, not an enlarged thyroid, and certainly not a multinodular goiter as I originally suspected. On further examination of the carotid, you can see in this video an intimal flap. So what this woman presented with was actually a carotid dissection. So let's now explore the ultrasonographic anatomy of the normal thyroid gland. This is a transverse sonogram, and the two lobes of the thyroid are joined in the midline by the isthmus. The trachea, the esophagus, the internal jugular vein, the common carotid artery, the anterior strap muscles, and longus colli muscles are also easily well visualized. The gland is nice and homogeneous, and the right lobe extends only to the edge of the carotid, so it's not enlarged. The isthmus is also nice and thin, measuring less than 2 millimeters. I turned my probe 90 degrees to get this longitudinal view. It gives you a nice image of the texture of the thyroid, and of course it gives you an image of the thyroid at a different plane. Let's note the position of the strap muscles around the thyroid gland. First note that the C is over the common carotid, and also the right side of the thyroid gland contains a small nodule, and there's a red area there indicating the nodule. The trachea is also noted in the midline. The S and SC stand for strap muscles and sternocleidomastoid. They're a little hypoechoic compared to the thyroid gland, and if you look carefully, you can see that they're striated.
It goes without saying that we need to measure each one of the nodules in the thyroid. Otherwise, we won't know whether they're increasing in size or not when we rescan them later. The red arrows demonstrate the thyroid beyond the limits of the right carotid. Thyromegaly is present when the parenchyma of the thyroid extends anterior to the carotids, as in this case, see the red arrows. White arrows demonstrate how to measure the thyroid in its AP and transverse diameter. Also noted with an E is the position of the esophagus posterior to the trachea. The isthmus in this thyroid is 7.6 millimeters, so there is thyromegaly. Remember that the normal thyroid isthmus is 3 millimeters or less. Let's review the characteristics of the normal thyroid. The normal thyroid is hyperechoic to the adjacent muscles. In other words, it's more echodense than the strap muscles or sternocleidomastoid which surround it. It is homogeneous throughout, looks a little bit like the testicular exam or perhaps the pancreas. It has scattered, readily detectable internal vessels. If you look carefully, the vessels actually go around the outside capsule of the thyroid and penetrate the thyroid from the outside. The lobes measure less than 2 centimeters in the anterior-posterior AP view and also in the transverse view. The thyroid also does not extend beyond the edge of the common carotid in the transverse view. And the isthmus is less than 3 millimeters.
This is a live scanning demonstration of the thyroid. I think before we begin, let's look at the probes. We're going to use a linear probe. They're usually 30 or 40 millimeters for the thyroid scan. These are high frequency and will give us a nice demonstration of the thyroid gland. Also, before we start, we want to make sure that we position the patient properly. You see on the bed, we have the pillow at the top of the bed. I'm actually going to move the pillow down. I'm going to have our patient lie with her head extended, a little bit farther more extended. There we go. So we hyperextend her neck so we have good access to the thyroid gland. I'm going to sit down to make myself comfortable so that I can relax a little bit and get good images. We're going to go ahead and put the linear probe on her neck, and you can immediately see her trachea, which is here. We see the isthmus of the thyroid here. We see the right lobe of the thyroid over here. There's a very thin capsule of the thyroid, which you can barely see here, and these are the strap muscles. Off to the side is the sternocleidomastoid. The edge of the thyroid is the carotid artery. This is her carotid artery down here. If I go a little bit farther laterally, you'll see her internal jugular as well. And beneath it, it's going to be the longus colli muscle. And on the other side, on the left-hand side, we see another structure, which is the esophagus. Now, the esophagus, most of the time, is on the left-hand side. It occasionally can be on the right-hand side. So when we begin to scan, we'll scan one side, whole way through the thyroid, forward and backward and out. And then we'll go to the other side as well. Now, many machines will have an extended view on their machine so that you can see the entire thyroid. Now, let me tell you also that it's going to be important to list the right and the left, as you always do in sonography. Now what we're going to do, I think, is to change the orientation of the probe, and we're going to scan through the thyroid gland in the other plane. And you can see it's nice and homogeneous, nice thin echo texture. We'll look at the other side as well. So this patient has a normal thyroid gland. We're going to want to measure the thyroid. Let me stop first by measuring the isthmus. The isthmus should be 3 millimeters or less. Her isthmus is actually 1.6 millimeters, so it's clearly normal. I'm going to go ahead and measure the thyroid in its transverse diameter.
and the thyroid should be less than 2 centimeters, and hers is 1.6. And we'll measure the AP diameter as well, and the AP diameter should be less than 2, and hers is 1.3. Now we can put color flow on there, and we'll do that and see what her color flow looks like. And generally, most of the color in the thyroid is around the outside, and you'll have branching arteries and vessels like you see here into the center of the thyroid gland. So again, this is a normal pattern for thyroid. In thyroiditis, you'll notice that there's increased flow within the thyroid. This is considered normal flow within the thyroid. The thyroid gland flow is very similar to other endocrine organs in the body. For example, the testicle, the pancreas will have almost exact, and the liver also, the exact kind of flow within the thyroid gland. Remember what we said at the beginning of this video. It's not recommended to scan generally without an indication like a palpable thyroid nodule, as you will find nodules in a large number of the general population. If we biopsy or do an FNA on all thyroid nodule, there'll be a lot of surgical procedures done on folks who do not necessarily need those procedures. Okay, so this is someone we should scan with a very enlarged palpable nodular thyroid. I was recently listening to a professor give a lecture on thyroid and thyroid nodules. He suggested that the sonographer should go for the low-hanging fruit. What did he mean by that? He meant that some thyroid nodules are almost always benign. Some nodules, when we scan, are certainly almost always malignant or look malignant. And then there's the third category, which is kind of where we're unsure, where they have mixed components. If we scan and the nodule is almost always benign in the first category, we can stop the evaluation process. If you want, you can scan at a later date just to make sure. Also, if we scan and the lesion looks malignant or is almost always malignant, we can refer it on for an FNA or a biopsy or surgery. And those that we are unsure about, really we can divide into 2 categories. We can bring them back and rescan them at 6 months, or we can refer them on to an endocrinologist for biopsy or follow-up. One caveat is that there can be some overlap between nodules, and some that are benign may be malignant and vice versa. So if the nodules have some characteristics of each one of the 2 categories, benign or malignant, it's probably best to follow those nodules or refer them on. If the incidentally discovered nodule is small, meaning less than 1 centimeter, and is cystic or has primarily cystic components containing debris, then it can probably safely be ignored. If the nodule is solid, then follow-up ultrasound exam or follow-up clinical palpation of the neck can be performed. If the nodule grows between the 2 evaluations to the extent that it is palpable clinically, then probably biopsy should be performed guided by ultrasound. Your evaluation is not complete unless you scan the lymph nodes bilaterally in the neck. If you're unfamiliar with the ultrasound appearance of benign versus hyperplastic versus malignant lymph nodes, be sure to watch the video lecture in this series on lymph nodes first. Okay, let's start and do this perhaps a little bit backwards, taking the malignant nodules first. There are risk factors for malignant nodules. They are a young age, male gender, rapid increase in size of the nodule, hard fixed nodules, the presence of regional metastatic nodes, and prior radiation exposure, especially to the neck. Solid nodules in the isthmus of the thyroid that bulge into the capsule because of mass effect and have tiny punctate echogenic foci within it have a high likelihood of being papillary carcinoma. These nodules may or may not have posterior acoustic enhancement. These small echogenic foci within the nodules are called psammoma bodies and are present in greater than 50% of papillary cancers. Even when the nodules are small and the calcifications are coarse, the nodule should probably go to FNA. Coarse calcifications can be seen in both papillary cancer and medullary cancer. Both need FNA or biopsy. The features with the best specificity for malignancy are microcalcifications. 88% of those are malignant. Central vascularization, meaning a large artery or vessel goes into the center of the nodule. 78% of those are malignant. Irregular margins, about 83% of those are malignant. And a taller than wide shape, 97% of those are malignant. What that means is the lesion is growing across the normal lobular septations of the thyroid. This nodule is solid and surrounded by a rather thick peripheral halo. The thicker the halo, the more likely it is to be malignant. Adenomas can have a small peripheral halo, but a halo this size with central calcification is almost always malignant. One caveat or exception to the sonographic differentiation between a malignant versus a benign neoplasm of the thyroid is the follicular adenoma or follicular neoplasm, as is in this case. What you see here is a solid lesion with a thin hypoechoic rim, both of which could be signs of a neoplasm or an adenoma. This lesion actually pushes on the capsule of the thyroid and distorts it somewhat, which makes one think that it might be more likely a neoplasm. Also, if you look at the interior architecture of the lesion, you will see what appears to be microcalcifications, which again leads one to believe that this might be neoplastic. If you do an FNA of these lesions, I am told from a pathology perspective that it is difficult to make the diagnosis by FNA, and FNA can only provide a diagnosis in 20% of the cases. Therefore, in this lesion, it's probably best to do a biopsy or an excision. Now, let's switch our focus to the benign non-neoplastic nodules, as in this case. These are small, cystic, non-palpable nodules. These are benign colloid nodules. They may be completely anechoic, or they may have some internal debris, or they may indeed even have some small echogenic foci within them, causing comet tail artifacts. These comet tail artifacts are from crystalline material giving a reverberation artifact, kind of like cholesterol crystals seen in the gallbladder. Small cystic nodules that are non-palpable are benign colloid nodules and need no further workup. This is an example of a benign non-neoplastic nodule. This is a transversed image of the right thyroid lobe. It shows a cyst in the lower pole of the thyroid containing an echogenic focus with ring-down artifact. In other words, this is a comet tail or reverberation artifact. This artifact is not calcification. You might want to look back several slides before to a lesion that looked very similar to this, but which had calcification in the center and showed shadowing beneath it rather than comet tail. This appearance is diagnostic of a benign colloid cyst. Now, if you just saw a still image of this lesion, you might think that it's a follicular adenoma or a follicular cancer. However, with a video image, it's clear that the nodule has multiple internal septations, described as like a sponge or honeycomb. This is a benign non-neoplastic nodule, a colloid nodule, and the honeycombing is characteristic of a non-neoplastic or non-cancerous nodule. This is a similar nodule, and this is what we mean by honeycombing or sponge-like, and this is again non-neoplastic. This is a large, predominantly cystic nodule and is almost never malignant, especially if there are multiple nodules in the thyroid that look like this. This is a large cystic nodule that contains internal septations or debris, not a simple cyst. These represent hyperplastic nodules. Predominantly cystic nodules have a high probability of being benign. Cystic papillary carcinoma does occur and can look like a benign cystic nodule. However, inside the nodule will be calcifications, and also cystic cancer is extremely rare. Now let's review the characteristics that we just discussed previously. Nodules with benign characteristics include nodules that are small, perhaps less than 1 centimeter, with cystic elements or primarily cystic. Cysts with or without some internal debris. Internal echoes within the cyst that show reverberation artifact or comet tail and no calcifications. Nodules with honeycomb or sponge-like appearance. Large, predominantly cystic nodules that may be single or may be multiple, and of course the diffusely enlarged thyroid of thyroiditis. Nodules with malignant characteristics include nodules that are entirely solid, nodules with tiny punctate echogenic foci that are calcified or psammoma bodies or microcalcifications, bulging of the capsule due to mass effect, in other words, when the nodule pushes on the capsule because of rapid growth, solitary nodules of the isthmus, nodules with central vascularization and the taller than wide shape, and nodules with irregular margins. Now lastly, let's look at another common problem with the thyroid, which is endemic goiter and thyroiditis and the painful enlarged thyroid gland. Worldwide, the most common cause of diffuse thyroid hyperplasia with gland enlargement is inadequate iodine ingestion or endemic goiter. In the US, the most commonly encountered diffuse thyroid diseases are chronic thyroiditis or Hashimoto's or Graves' disease. Now let's look at thyroiditis. This thyroid has multiple hypoechoic nodules within its both lobes. This is called micronodulation and is most often seen in Hashimoto's thyroiditis in the United States. There is diffuse enlargement of the thyroid. If you apply color or power Doppler, you will find increased flow within the gland, especially in the acute or active phase. This has a positive predictive value of greater than 95% for thyroiditis. This is a different patient with thyroiditis, but you can easily see the increased flow within the gland by power Doppler. Micronodulation is a little difficult to visualize, but if you look carefully at the superior portion of the gland, you will be able to visualize the micronodulation. So this is thyroiditis. Hopefully after this lecture, the thyroid gland won't seem so scary. Thanks for your attention. This is Dr. Ted Kuhn.